This short video is on patient information on frozen shoulder. First question is, what is frozen shoulder? Frozen shoulder is a very general term where patients experience pain and stiffness in the shoulder. The pain comes on usually fairly acutely, often precipitated by minor trauma, what generally happens out of the blue. The pain is worst at night time, and often patients describe as a throbbing pain. Worse on movement, especially with stretching. Typically, patients who have been to physio would report that the pain is actually made worse with any attempted physiotherapy. How do you diagnose frozen shoulder? So typically a patient would present with the symptoms as I've described. No age is barred, but commonly seen between the age of 30 to 50, maybe up to 60 years of age. With pain and examination will show global restriction of movements, and especially when you examine the patient, if you do that, if it's painful and stiff, mainly stiff in that movement, then that typically is a diagnostic of a frozen shoulder. An X-ray is required to rule out other causes of a painful and stiff shoulder, which is arthritis or a dislocated shoulder. The risk factors for frozen shoulder include diabetes, especially if it's uncontrolled or poorly controlled diabetics. The diabetics also run quite an aggressive course and can have recurrence of frozen shoulder, and sometimes take more than one intervention to give them a pain-free mobile shoulder. The other risk factors include underactive thyroid, raised cholesterol, as well as patients who have underlying inflammatory arthritis like rheumatoid arthritis. Of course, the other group of patients, which is called a secondary frozen shoulder, is ones where they have had previous surgery, especially if they've had some sort of reconstruction or stabilization type of procedure. Also, patients who have a stiff shoulder prior to a keyhole surgery have also increased risk of getting a frozen shoulder. The risk of a significant frozen shoulder after any other keyhole surgery is less than 5% that will require intervention. The treatment options for frozen shoulder is always done based on discussion with the patient, their medical background, their symptoms, their expectation. Broadly, the treatment options include physiotherapy and steroid injection in clinic, and in this the patient's expectation or the idea would be to give them some pain relief, and the physiotherapy would help them regain the movement. Just the injection itself does not help increasing the range of movement. The second option is doing a hydrodistension or hydrodilatation, or called glenohumeral joint release, which I undertake for vast majority of the patients, especially if their symptoms have been less than 9 months to a year. In this procedure, I undertake a large volume distension of the ball and socket joint. I perform this under a general anesthetic, as I feel that this is quite painful condition to begin with, and introducing any injection causes the more pain. And what the injection does, it makes the shoulder joint open up, providing movement. I also put local anesthetic and steroid, which helps with the pain relief, and after that they have physiotherapy. In patients who have resistant frozen shoulder or they have failed other treatment, then keyhole surgery is what is recommended. In this, what I do is release the lining using special radio frequency, like an electric probe that cuts through the tight joint lining, providing improved movements as well as pain relief. As I said earlier, this is all tailored according to the patient's requirement. So this depends on what surgery or procedure has been undertaken. If I'm doing a hydrodilatation or distension, then patients in hospital for 2-3 hours time is a fairly quick procedure wherein I inject a large volume of liquid into the shoulder under X-ray control, so that I can be certain that the injection's gone in the right place. After this, the patient starts to get the shoulder moving pretty quickly. Patient is having keyhole surgery, then this is a bit more involved. Requires a general anesthetic and a nerve block, which gives good pain relief after the procedure. In this procedure, the lining of the shoulder joint, or the capsule as we call it, is released using special instruments. And also I do the removal of the spur from the shoulder blade. At the end, put some steroid injection into the ball and socket joint to reduce the incidence of it retightening. Following this, the keyholes are closed with butterfly stitches and dissolvable stitches, and the wound is closed with sticky dressing and a pad. The arm is then placed in a sling. Patient returned to the ward, and physiotherapy starts as soon as possible. Post-op recovery depends on the type of procedure. If it's a distension release, then patient starts to get the arm going almost immediately as soon as the pain allows, and they're back to usual activity after 24 to 48 hours. If the patient has keyhole surgery, then this is a bit more involved, and the shoulder is a bit more sore for the first few days. But again, the key here is to mobilize the shoulder as soon as pain allows, to avoid the shoulder becoming tight again. So you can start to do simple things as you feel comfortable. The sling can be discarded as soon as pain allows. You will be monitored by the physiotherapist in the outpatient, and an outpatient appointment to see myself will be arranged between 2 to 6 weeks after the surgery. Most patients do need outpatient physiotherapy. This will be discussed and a bespoke plan will be arranged for each patient. The therapist will see you on the ward before you're discharged and will arrange appropriate outpatient appointment. Essentially, the sling is taken off as comfortable and the shoulder is started to mobilize as pain allows. Please watch my video on simple shoulder exercises for the initial stages. If you have any queries or concerns, please check with myself or the therapist. Ability to drive depends on the type of procedure, the pain level and the movements, as well as what sort of car a patient has and which side is involved. So for example, if it's a injection release, then you're back to doing most things within a couple of days. If it's a keyhole surgery, then this will be dictated by the level of pain and discomfort. Most patients, however, start to drive anywhere between 5 to 10 days after the surgery. I always advise patients to let their insurance company know about the procedure. Although keyhole surgery is very safe, there are still complications related to the general anesthetic and the nerve block, which is rare. Most specific complications include wound healing problems, infection, some bruising around the shoulder, which is commonly seen, pain persistence. Most relevant is persistent shoulder stiffness, which in my practice I see more commonly in patients who have diabetes or other underlying conditions. There's also risk of tear of the tendon and the ligaments around the shoulder, but again, overall, this is pretty low. Return to work depends on whether you had an injection release or a keyhole release. Following an injection release, I generally advise patients to rest for 24 to 48 hours and then they can go back to their pre-injection level of use of the arm as long as pain is under control. If it's a keyhole surgery, then it depends on the type of job as well as what support you have at work. So typically patients can go back within a few days if they're office-based work, and they can work with the sling on for the few days. Light duties start at about 4 to 6 weeks, and then any heavy lifting or moderate work varies between 8 to 12 weeks. I would always advise to speak to your line manager or your occupational health. I'd also be happy to advise you based on your requirement. Thank you for watching this information video. Hope you liked it. Feedback would be appreciated. Thank you.